He speaks.
Hello, welcome. We have today Dr. Raman Muthusamy from UCLA. We're going to talk about Castle and Tissue Cypher today. Dr. Muthusamy, can you tell us what Tissue Cypher is?
Right. Good morning, Phoenix. Good to be with you. And so Tissue Cypher, is also known sometimes in the literature as tissue systems pathology, is sort of a predictive tool that can be run on tissue specimen that incorporates 9 biomarkers and 7 structural features of cells, which are extracted sort of automatically and then incorporated into a stratified risk score, which allows you to predict the potential for progression of your patient who has Barrett's to high-grade dysplasia or cancer.
That's very nice. How is it done? Do we biopsy and send it out?
Yeah. So it's run typically on sort of pathology specimens. So typically formalin-fixed, paraffin-embedded sort of specimens typically, and it can be done on sort of specimens that you're obtaining and a patient you're seeing in the endoscopy unit on that day. But the nice thing, Phoenix, is that you can also run it on specimen that you've already acquired from somebody that's from 6 months ago or a year ago. And if they have a question to see you in the office, you could potentially say, well, let me run it on the specimen, and then we can decide your management going forward.
Is there a specific area we should biopsy or anywhere? Do we care?
Yeah, I mean, ultimately you should take your usual Seattle protocol biopsies. It'll be run usually on, one or more of those sites, because there is some ability to predict the field effect from the specimen, but oftentimes, especially in someone with long segment, the potential for assessing multiple sites does exist. That's right.
Are we able to tell Castle which area we're more worried about, less worried about? Can we differentiate the biopsy?
Yeah, I think you can certainly, emphasize particular areas that you want. I think in the report when you fill it out and so forth. But most of the time we're going to biopsy visible lesions anyway separately. Right. So you're going to have your pathologist look at that, and then this is going to be able to look at the other areas where that maybe you didn't necessarily suspect something to see what type of field effect may be present and what the potential risk is.
Very nice. And large biopsy forceps, small, regular, doesn't really...
In my practice, it hasn't really mattered. I tend to use a larger forceps just because I like to get extra tissue potentially, but yes. I don't know that it necessarily is mandatory, and I think it certainly could be run on either.
Okay. The common question I get is, should we send it from the lab when we're doing the biopsy, or should we wait until the biopsy comes back and you have the pathology results, then send the tissue cypher? What is your practice?
Yeah, I mean, I think in my case, I probably do the latter, because if I'm scoping a patient and I already have confirmed low grade, and if the patient's already told me if I have low grade, I want to be treated, then we probably don't need it. But I think it's a good, and of course the nice thing about it is that kind of links back to the fact, Phoenix, that we can send this after anyways. It's not like it has to be sent, or you don't have to take an extra biopsy and run it at the time. Right. It can be run on an existing specimen, so you do have that luxury of waiting for the results and sending for it later if you need it.
Gotcha.
Yep.
So you're sitting in front of the patient's talking to you about the results. Do you discuss with them before you send the test, and what happens? What's the process?
Yeah, usually I tell them in advance, or usually on the day of the procedure, like, look, I'm going to take some biopsies, we'll see what we have, and then if we still have a lack of clarity, or if we need additional information, we'll run this test, and, do I have your permission to do that? So it's already sort of set in advance when I do the procedure as to the algorithm, and if obviously I have pretty clear results, then we'll do that, and if I need additional information, which is what Tissue Cypher provides, then I would send the patient the sample for testing.
Very nice. So can you review for us your algorithm? So you did the biopsy, you have the result. What is your thinking?
Yeah. So typically, I find this useful in 3 scenarios. So one scenario is the patient who has a history of non-dysplastic Barrett's, who's very anxious and perhaps is leaning towards maybe considering eradication for various reasons. And this can help, if they're a high-risk patient, the data suggests that their risk of progression is actually equal to or greater than that of a low-grade dysplasia patient by pathology. And so that would serve to reinforce their notion that perhaps they should be treated, or at the very least have their surveillance interval shortened, right?
Yes.
So I think, on the other hand, if you do get a low risk score, you could reassure that patient that, hey, I know you're concerned, but the data suggests that your risk of, and it's a 5-year risk that you're going to get, so it's going to tell you it's not for your life, it's for the next 5 years. So it'll tell you what your risk of progression is. And so you say, at least for the next 5 years, it looks like your risk is very low. We could probably consider surveillance. Now, that's probably the most common scenario of Phoenix, but a couple of others. Sometimes you get a patient who's got indefinite for dysplasia. You're not really sure. It's in between low grade. It's in between non-dysplastic. What do I do? And so that's a case where I think if you run a tissue type for test and it's sort of intermediate or high, I would lean toward, again, attenuated surveillance or even potentially eradication therapy. Whereas if it was low, you could consider just, again, surveillance at some interval. And then the low-grade patients, I think, the most recent guidance is that it's the AGA guideline that just came out suggests treatment for those patients. But if you have a patient who is particularly hesitant or reticent about endoscopic, they're maybe procedure averse, you could use a tissue Cypher test to either prove that, yes, your risk of progression is high, or if they're a low-risk, low-grade patient, perhaps you could just put them in frequent surveillance and sort of manage them that way. So in my practice, I think those are the 3 scenarios that I typically see.
There's value in both, the positive and the negative.
Correct.
Do you have intermediate scores on tissue Cypher?
There is an intermediate score. The intermediate score, though, tends to have a risk that's at least equal to a low-grade dysplasia patient. So I tend to use an intermediate almost as a positive, at least in my practice.
Right.
And so I would recommend either treatment or shortened surveillance in the patients who score intermediate.
Very good. Yep. How about a case where you think the patient should be ablated, and does the tissue Cypher result help to convince the insurance to approve for an ablation?
Yeah, that's really a great scenario in that you've got a patient, maybe long segment Barrett's, but non-dysplastic, 35 years old.
Right.
Typically, a lot of insurance companies say, "Well, this is non-dysplastic, we wouldn't do it." But
has it helped?
That's it. I think it has, and in my case, and with effort, sometimes there may be a little resistance, but when you provide the data, which I think is quite robust at this point, that we've, in a limited number of cases like this, we have been successful. So that's been my experience, at least.
Well, talking about insurance, can you tell us a little bit about reimbursement for tissue Cypher? Have there been issues, or is it covered? Yeah,
the nice thing about it is for physicians who are worried, they have received sort of a special Medicare status for diagnostic tests. So that really doesn't come easily, and again is really done for tests that have a strong evidence base.
Right.
And so the company is very confident about their ability to, be adequately, reimbursed on their end. And so, basically they don't, they'll submit to insurance, but if for whatever reason they're not able to be successful, which my understanding is quite uncommon, but if that's the case, they have a policy where they don't secondarily bill the patient. So you're not going to have the unexpected scenario of your patient necessarily getting a large bill because their carrier, was not in agreement with reimbursement.
Right. Do you use information for further intervention, for example, GERD intervention, like hiatal hernia repair or fundoplication? Do you incorporate that into your management for patients with GERD?
In terms of patients who also have Barrett's with GERD?
With GERD, yeah.
Yeah. So, I think certainly, patients who have this, one of the things especially if we do eradication therapy, we know that the single biggest risk factor for recurrence after eradication therapy is uncontrolled pH, right? So patients who have an increase. So those patients warrant at least very aggressive anti-acid suppression, or, as I think you may be alluding to, consideration of anti-reflux procedures, whether they be endoscopic, such as TIF, or surgical, such as some form of fundoplication or LINX.
That's wonderful. Thank you for your very knowledgeable assessment of tissue Cypher.